So, good evening, and dear colleagues, dear faculty and speakers, ladies and gentlemen, thank you very, very much for the joining the meeting today. Today is our third meeting in the EndoEnage. The EndoEnage is an initiative where we started in the European Endometriosis League, the EEL, to involve and engage with all stakeholders and healthcare providers and also patients related to endometriosis. So today, because March is the endometriosis change month, we are very keen to have not only a one-way discussion, but a two-way discussion with our colleagues and with our patients, and with an outstanding faculty that I'm so grateful for their time and for their effort to join us today to be able to engage with our patients and to answer their questions. I cannot thank enough the young team who have been behind the scenes trying to arrange and make all the arrangements and the emails and the Zooms and everything for this meeting to happen. So thank you so much, and I will not take much of your time. I can see that we are more than 150 participants now, so I will not waste time. I will give the word to my co-moderator, Prof. Annemiek Knapp. I'll just introduce myself. My name is Mohammed Mabrouk. I'm a consultant gynecologist, and I work in London, in the University College London, and I'm currently the president of the European Endometriosis League. Thank you very much for everyone. Annemiek, please.
Thank you, Mohammed, for introducing me. I'm very glad that we have such a large audience this evening, and also we have a very nice faculty. My name is Annemiek Knapp. I'm a gynecologist and professor of reproductive medicine in the Radboud UMC in Nijmegen, the Netherlands, and I'm treasurer of the European Endometriosis League. And I would like to give the floor one by one to my co-persons in the faculty. Please introduce yourself in only one sentence because we have a large group. Pavel, could you start? Pavel Basta?
Yes, of course. Good evening, everyone. Good evening, Annemiek. I'm a gynecologist from University Hospital in Krakow and a board member of EEL. Thank you.
Thank you. I'm not sure, Attila Bokor. I don't know if he is around. I didn't see him yet. Attila, I think you're not there. So then we will move to Professor Elvira Bratilla.
Hello, good evening. I'm Elvira Bratilla, professor at University in Bucharest, gynecologist in Romania.
Thank you. Alin, Constantin?
Yes, good evening. I'm Alin Constantin. I'm a consultant in OBGYN working at the Saarland University Medical Center in Germany.
Thank you. Dr. Rami Issa, I didn't see you yet. Are you there? No? Then Ligita, I've seen you.
Yes. Good evening, everybody. So my name is Ligita Jokopkina, and I'm an associate professor at Lund University in south of Sweden. I'm also a senior consultant at Skåne University Hospital, which is also in south of Sweden.
Thank you. Professor Keckstein.
Hello, good evening. I'm Jörg Keckstein. I'm a consultant in Austria, and I'm also professor at the University in Ulm. And at the moment, I'm the chair of the SIG in the ESGE.
Thank you. Shaheen Ghazali.
Hi, I am a gynecologist. I work in London at the Lister Hospital.
Guri Mayak.
Good evening. I'm a gynecologist at Oslo University Hospital in Norway and the head of the National Advisory Board for Endometriosis and Adenomyosis in Norway.
Thank you. Mario Malzoni, I didn't see you yet. Are you there?
Well, Mario actually sent his apologies.
Yes, you're right. Sorry.
He's not here today.
Yes,
And,
John.
John Morton.
I've seen you. Yes.
Hello, thank you. My name is John Morton. I'm a colorectal surgeon at Cambridge University Hospitals. Thank you for joining.
Thank you. Dr. Tamer Nafi.
Tamer. Okay. Apparently,
no, he's not
he
there.
hasn't joined yet. He will join.
And Philippa, I've seen you. Philippa Osorio, welcome.
Hi, good evening. I'm Filipe Osório, and I'm consultant in Lisbon, Portugal, in Hospital da Luz.
Thank you. Atanu Paul, I didn't see. Yes, I've seen you now.
Here he
Yeah,
is.
go ahead.
Hello, good evening. Lovely to be here. Atanu Pal, consultant surgeon at Cambridge University Hospitals in the UK.
Thank you. Ovidiu Palea.
These are our pain therapist.
Yes, he's not there, but I have seen Noor Paridans from the
Noor
Netherlands.
is here.
Yes, good evening. My name is Noor Paridans. I'm a gynecologist in the Nederlandse Endometriosis Clinic, an expertise center for the treatment for endometriosis in the Netherlands.
Welcome.
Very
Ertan
good.
Saridogan.
Good evening. Hello. My name is Ertan Saridogan. I'm a professor and consultant gynecologist at University College London and University College London Hospital. And I'm the current president of the European Society for Gynecological Endoscopy.
Fantastic. Nice to have you. Dr. Soldevilla. No. But Taner Usta, I've seen. Hi, Taner.
Yes, Taner is here.
Hi, Anemik. My name is Taner Usta. I'm a professor. I'm working in Istanbul, Acıbadem University, and also I am a consultant in Acıbadem Altunizade Hospital. Also, I am the executive board member of EEL.
Thank you. Arvind Vasist.
Good evening, I'm Arvind Vasist. I'm a gynecologist at University College Hospital, London.
Thank you. Diane Fox.
Hi, my name is Diane. I'm a psychologist and a professional researcher, but I am the Nancy's Nook representative for the UK.
Thank you. So I think we have now introduced the whole faculty. Is there anybody I forgot? No. Well, then I would like to give the floor to Alin, but not after I have encouraged you to have a vivid interaction with all of the faculty, and please do ask questions in the chat so that we can send the question to the right person in the faculty. Alin, I will give the floor to you now.
Yes, thank you, Annemiek. So before continuing, we'd like to thank Gideon Richter, who has been our sponsor for the last 5 years. And please allow me to share a short video with you, and then we can proceed.
What does it take to make a medicine? You need to shift your perspective to see success comes from a series of innovations. Without the dedicated work of our highly trained researchers, no such progress would be possible. It is today that experts need to think about the diseases of tomorrow, and premium quality requires the latest technology. All these aspects come together to create new treatments that will improve the health of millions. This is what we work for every day. Gideon Richter, health is our mission.
Thank you for your time. And now I'm giving the floor back to Mohammed.
Well, thank you again, Alin. And now we will, just for the questions, there is a box for the Q's and A's. So please ask all the questions you want. We are here to interact and to answer the questions that you have. We have now 220 participants. And we will maybe start by asking some questions till we have questions from your side. And the two gynecologists, okay. So we will read the questions now. And here I can see that we have the first question. Hi, everyone. Thank you so much. Thank you very much. And okay, we have the Endo Hope from New Zealand. So thank you very much, Philippa, for joining today. And we have also another question here about the decision-making in endometriosis. So, and I would start with this question with Kickstein, Jörg. This is a question that's asking about two gynecologists state that patients need a hysterectomy, and two others say no. With facts, shouldn't there be one conclusion? I'm very confused indeed about my diagnosis. And this will take us a little bit, Jörg, to the role of hysterectomy in treating endometriosis, and what's your view considering your extensive experience about endometriosis treatment over the years?
Yes, this is a very good question, and this question represents a very old tradition that with hysterectomy everything is solved. This is very important. I think sometimes hysterectomy is indicated to do it, especially in severe adenomyosis and failing with conservative treatment. This is at the very end of a long story. And it depends on the age of the patient, of the history, and also it is very important that the diagnosis is made. What is the reason to remove the uterus? If there is no pathology within the uterus and the symptoms are outside, coming from deep endometriosis on the ligaments or on the bowel or else, some other places, then hysterectomy would probably not help. And that's why so important, and I come back to the classification. I just say we need a good workup before we do any indication. And we have to identify the lesions. And if at the very end, the uterus is the main cause of the symptoms which cannot be solved by conservative treatment, hormonal treatment, or also by debulking surgery or by uterine device, hormonal device, then hysterectomy is indicated. Then when this question, coming back to the question, first of all, we need not the indication, we need the diagnosis. This is so important. We need a complete workup. And if there is a sign, diffuse adenomyosis, big uterus, no other signs of deep endometriosis, then probably hysterectomy would be the right decision. And that's why I always insist that the patient should be informed about the complete disease. And then we can find out where is the right way. That's my answer.
Thank you very much, Jörg. I hope this, I'm sure this is a comprehensive answer, and I hope for our colleague or patient who asked this question, she found a clear answer. Annemiek, would you like to take Marie Miranda question?
Yes, thank you, Mohammed. The next question that I can read for you is, hello all, I live in London, diagnosed after 3 years with deep infiltrated endometriosis in my bowel, referred for laparoscopy but scared of the high rate of endo coming back after surgery. Also, I'd like to try IVF, but not sure whether to try before or after surgery. Yeah, I think that's a very difficult and also very relevant question.
Maybe Ertan can answer
yes,
this.
I was just thinking about Ertan to answer this. Please, Ertan, go ahead.
Okay, thank you. I'll start with the IVF part. Obviously, we don't know the age of the person asking question, but that is an important consideration. And duration that they have been trying for a pregnancy. These are important factors to take into account. For young people who have tried for a pregnancy for relatively short duration, surgery first is a reasonable option. And in that situation, it is also possible that chances of pregnancy spontaneously, naturally, may increase substantially. And this may be the chances of success may be as high as what we would expect from IVF, cumulative cycles of perhaps as many as 3 cycles. But for older people with relatively longer duration of infertility, it may be better to consider IVF first. Because sometimes surgery for bowel endometriosis would cause delays in implementing effective fertility treatment, and that can sometimes be detrimental to the chances of success for IVF. So these are the factors I think we need to take into account. The first part of the question, yes, endometriosis obviously is considered a potentially chronic condition, and there is a significant risk of recurrence. But on the other hand, if you look at outcome data following surgery, at least 2/3 of women have good long-term improvement of their symptoms. So if the person is prepared to undergo surgery, then I think long-term outcomes are not necessarily disappointing.
Thank you very much, Ertan. And I can see that, Mari, I'm sorry that you had a diagnosis after 3 years. And I'm sorry for all our patients because we still have delays in diagnosis. And I think we're all the experts sitting in the room here are doing their best and really to try to mitigate and try to find a solution to reduce the time from symptoms to diagnosis. Just one quick comment on the recurrence. Don't be scared from the recurrence. Not all patients have recurrences. We have 1 in 5 of the patients who have recurrence in 5 years' time. So don't be scared. It can recur, yes, but this is not mathematical. Shall I take the next question, Annemiek?
Yes, go ahead.
Okay. Here we have a big thank you and also a big question mark. And I think this is one of those £1 million questions about adenomyosis. And maybe we can ask this one to Shaheen, because it is about adenomyosis and is it a form of endometriosis? And do you do the same, advise the same, and give the same advice to endo patients and adenomyosis patients, or there is a difference in the treatment?
Okay, so that's you're very cheap, Mohammed. £1 million this is quite a lot more. So I want to make it even more complicated. We don't even know if adenomyosis is one disease itself. So we have adenomyosis that is coming from outside the uterus through the outside lining of the uterus towards the inside. And we have other types of adenomyosis that seem to be starting from the endometrium. And there are some cystic lesions under the endometrium. So there is now a suggestion that maybe these two types are two types of different diseases. But if I'm to answer the question broadly, we know that these two conditions are very close relatives, at least. They may not be exactly the same conditions, but they're both represent endometrial type tissue growing where they're not supposed to be. In case of adenomyosis, they grow inside the muscle of the uterus. In case of endometriosis, they grow outside the uterus. But in many cases, the treatment is similar. There are exceptions. For example, we know that both of these conditions are estrogen dependent, and therefore medical therapies that address this can work in a positive way on both. With endometriosis, surgical management is more readily available. With adenomyosis, surgical treatment is more difficult, and particularly if a patient has fertility wishes. But we are still very far from finding the answer to this question.
Thank you, Shaheen.
Yes, I will take the next question, and I will take it not from the chat, but from the email that we received before. And I would like to invite Philippa to answer it. One of the questions that we received was, how common do we find endometriosis in patients with symptoms? Could you comment on that, Philippa?
Well, the majority of patients that have symptoms, and we can say symptoms has dysmenorrhea, pain when going to empty the bowel or the bladder, pain during intercourse. Those patients that has the characteristic symptoms, we can associate it in most of the times to endometriosis or even to some cases of adenomyosis. There are only just a few patients that we cannot find disease by the pre-op workup. That means that we cannot find disease in either ultrasound or MRI, but there are only just a few patients. On the other hand, we can also have patients that have endometriosis and without symptoms. And we can even have patients with deep endometriosis without any kind of complaints. And we cannot explain that, why that happens with some and not with the other ones.
Mm. Ligita wants to comment on that, I think. Ligita, you are still muted.
Yes, so I think very nice explanation, Philippe. I would like just to add, because we did a study on that, and we actually, we are a referral center for patients with symptoms for an ultrasound examination. So I'm working in that ultrasound department, and we have looked at our patient data since 2014 for all patients that has been referred because of the symptoms that's suggestive of endometriosis. So we have found that 1 out of 4 of patients with symptoms had endometriosis at ultrasound. The ultrasound has been performed by an expert who is well trained and have been performing many examinations. So, and what was very interesting was that 50%, so 1 in 2 of patients, did not have any changes at ultrasound. Of course, we were not at that level to exclude peritoneal endometriosis, but we performed it very systematically. So, and then the remaining patients had PCOS or myoma or any other reason. So that was very interesting. And then we also did a study in patients with infertility or subfertility, those that have been referred for their first IVF treatment. We scanned more than 1,000 patients and also found that 1 in 4 about had endometriosis. But 4, so 75% didn't know about the disease. So again, we have about similar prevalence of the disease in this patient group patients. So it says that patients may have symptoms, and of course we do not expect to find the disease in every patient. But again, if we work at like a surgery center where we get patients referred with advanced disease, so the prevalence will be much higher because they are selected patients. But again, symptomatic patients, I have no idea. We did a small study many years ago, also looked at asymptomatic premenopausal women. We unfortunately did not perform very carefully examination of sacroiliac ligaments, but I think endometriomas, the endometriosis in the ovaries, we have found in like very, very few cases. So that's interesting, but unfortunately, it might be detected, but maybe we don't know also the importance of that in asymptomatic patients. Thank you for.
Thank you very much, Ligita. That's a very important point actually that you're raising here. And I mean, we comprehensively answered the previous question, and we have so many questions, and I'm very happy with this. So now we will take a question from LSPA to everyone. Well, it'll take us actually to an important topic with endometriosis, and this topic is one of the hot ones, which is dysfunctions related to endometriosis. Because sometimes we see endometriosis as a lesion, we see endometriosis as an ovarian cyst, as a lesion on the bowel, as a nodule on the bladder, etc., etc. And we treat endometriosis, but the objective in treatment is not only lesion-oriented, it's a problem-oriented, and more importantly, should be function-sparing. And this is the balance that we always try to make when we are treating endometriosis surgically. And here there is a question that maybe I can ask it to my colleague and friend Arvind Vashisht about the dysfunctions. And this is a question coming about hypogastric nerves, Arvind. And would it be better if there is a large, deep endometriosis lesion occupying or affecting both hypogastric nerves? Would it be better to leave tiny lesions behind to preserve the nerve and the function, or all lesions must be resected, eradicated, and how to manage urinary dysfunction after deep endometriosis surgery?
Okay, Mohammed, yeah, thank you. I think it's a question that increasingly surgeons are aware of. in that you very rightly say, and some of the other answers and speakers have said that actually treatment of the disease is not just about the disease itself, but it's related to the patient, and you want to direct it according to the symptoms a patient may present with. But also you need to bear in mind some of the pitfalls of very aggressive surgery and what the outcomes may be if you try and chase every lesion down. So every surgeon, I think, is trying to balance what the patient's treatment wishes are, be it fertility, be it radical clearance, but also mindful of the potential for complications during surgery itself and longer-term complications. This specific question then asks about the nerves itself, and I think this is a growing field within the surgical treatment of endometriosis. Surgeons are increasingly identifying those nerves, all-important hypogastric nerves that most surgeons now have it in their brains as part of the training programs that have been going on. And so it is very important where possible to, just like we identify the bowel, just like we identify the ureter, we identify the hypogastric nerve, because it is so important in lower urinary tract symptoms, bowel function, sexual function. Specifically, the question also asks the question, if you see it on both sides, there are different schools of thought. Even today, in fact, we had a similar case where we had disease involving both of the hypogastric nerves, and we decided to be conservative, at least on one side, so that actually we weren't going to jeopardize the medium and long-term voiding problems with patients. So I think it's an alertness before the operation in terms of asking the patient about functional bowel and bladder symptoms. It's an awareness during the operation itself, and it's also about being mindful following the operation. For us, we have quite strict protocols in terms of catheter management after radical excision. So look, I mean, it's the kind of question that we could speak about all day, but I hope that that's given a snippet of a surgical perspective of managing nerve function.
Thank you, Arvind. I can see that Tanner you had a raised hand, Tanner. You want to make a comment, please?
Thank you, Arvind, about your comments. Normally, we know that this is a sensitive nerve. So you can feel the bladder. Also, it can have some functions about ureteric sphincter. And this is not have some motoric functions on the bladder and also the bladder. But we know that when the disease affected that tiny nerves, it's a very tiny nerve, and the superficial one, we can make some damage on the sensitive functions of the patients. But on the other hand, also endometriosis can make that damage still there and make some damage there. So the main point is important. If you want to preserve the function, if you want to preserve all organs in a normal conditions, that is the point. So, but the main point is not that nerve. The other nerves, like a subplanchnic nerve, which is parasympathetic one, which is laying on the deepest part of the pelvis, very important than this one. Also, Arvind talk about that. If the lesions is unilateral, it will not make a big problem. But if you have a bilateral lesion and you cut all lesions on the bilateral side, we will face some motoric functions, and it's very badly affect that lady's life. And so we have to know that conditions before any decision, before the surgery, like Jörg mentioned before.
Well, we could discuss this theme until the end of the evening, I think. But there are so many other questions that are asked, and I would like to give the floor to Noor Paridans about a very different question, a very basic question. What is the difference between endometriosis and ovarian cysts? Noor, do you think there is a difference?
Thank you for the question. Well, I think, as stated before, that all endometriosis and also adenomyosis is estrogen dependent. But in terms of what it looks like when you have a diagnostic, when you do your diagnostics, it can look different. So it has different signs of how we diagnose it and how we score it. So I don't know if that's what was meant with the question, but it looks different on ultrasound, on MRI, and during surgery. but both are also estrogen dependent. And we do know that the chocolate containing cyst in ovarian endometriosis is sometimes also seen on other locations, for example, in deep invasive endometriosis nodules. But it is completely different from peritoneal endometriosis. And this is also the reason that we say that ovarian endometriosis is a different type of endometriosis.
Thank you, Noor. Thank you very much. And here we have another question, which is a bit also one of those £1 million. Who would answer here? Okay, let's ask Pavel. Pavel, here there is a question about the non-invasive tests for endometriosis. You know that now we have tests in the blood, some in the saliva, some here, some there, and the specificity, the sensitivity, the positive, negative, whatever, the overall accuracy, because here someone is asking for a non-invasive test for her 18-year-old daughter to make a diagnosis of endometriosis. What's your thought about this, Pavel?
Thank you, Mohammed. I think this is a very important and interesting question. As you mentioned, now there are three tests available on the market. One is EndoMRI from Celiac, which has been probably at least partially validated. Then we have a test which is based on neurotrophic brain derived factor plus level of CA125 and the combination of few questions. So it's a combined test. And this is the test basically based on blood sample. And now we have in Poland at least a test which is a sample from a uterine cavity based on 4-fucosyltransferase expression. The problem with all those tests is that they are not properly validated yet, which means it is very difficult to recommend them as a reliable test to stratify and to triage patients. And if I may make a kind of a referral to what Ligita and Filipa said about the percentage of patients with symptoms which have endometriosis, in fact. Judging by our outpatient department, we have noticed that half of the patients with symptoms suggest endometriosis have no signs in combined MRI and ultrasound tests done by experts, which means there is a huge room for non-invasive tests, especially for adolescents, which as you know, it's a special group of females who required a very thorough workout. And yes, this is a question for probably more than $1 million. This is very important. But as far as my opinion is concerned, we have no validated tests till now which we can recommend. At least I couldn't know about any of them.
The expert panel that we have here, anyone has a different opinion in the saliva test, blood test, non-invasive markers, etc. so far, at least in the phase where we are now, that he would recommend for his patients? Any one of the experts that are here? So we almost all agree on what Pavel has just said. I just would like to remind all of us that ultrasound is a non-invasive test. Ultrasound is a good non-invasive test, and done by expert hands, it helps a lot in diagnosing endometriosis. And MRI is also non-invasive test. Laparoscopy is, yes, I agree, but we don't do laparoscopies unless we have imaging that gives us an idea about what we have and how we have it. So there are some steps before the invasive laparoscopic diagnosis or treatment of endometriosis to know what we have, but we cannot yet recommend one of the non-invasive tests that are available in the market because we don't have scientific evidence, a strong scientific evidence to let us know that these markers or these tests are valid. So we have another Annemiek. What do we have?
Yes, we have another important question from Alexandra Paske. And she says, I'm a celiac patient, recently diagnosed with endometriosis due to the problems with getting pregnant. I was told there's an option for IVF, but I decided to do the laparoscopic surgery first. My question is from your experience, is it possible as a celiac plus endo patient to get pregnant naturally after laparoscopic surgery, or should I undergo IVF? And I have been looking through the panel, and I would like to ask Elvira, could you answer this question? Do you feel comfortable with that?
Okay. Yes. Celiac disease is not really related with the indication of IVF. The main reason of infertility in this situation could be endometriosis, and after laparoscopy, depends of the tube, depends of the ovarian reserve, depends of the age of the patient. These are all key factors that influence fertility more than celiac disease. Because, for example, I had a patient with celiac disease. I had patients with sensibility to histamine and infertility, and I manage and endometriosis too, and I manage endometriosis laparoscopically, and they become pregnant after surgery. So the main reason and the main indication of IVF is not celiac disease.
Yeah, I totally agree. And I think she could have a chance to naturally conceive if she is not too painful to have intercourse at least. Yeah. Mm-hmm. Okay,
Perfect.
Mohammed, back to you.
So for our 250 participants who maybe have just joined, we are just reminding you that we are in the EndoEnage event, and this is an open forum roundtable with a panel of experts experienced in endometriosis, all of them except myself. And we are just discussing and answering the questions of the patients and the colleagues. And welcome and thank you very much for joining us. We have two colleagues, two panels, two experts who have joined, but we after we made the round of introductions, Dr. Alessandra Di Giovanni from Italy and Dr. Nafi from Manchester. Can you please introduce yourselves quickly?
Alessandra, you're muted.
Oh,
yes.
I go first. Okay, thank you. Thank you, Mohammed, and all the panel for inviting me. It's a great opportunity. I'm a gynecologist, mainly sonographer, fully dedicated to gynecologic ultrasound, of course, in endometriosis and also oncology. And I'm used to work in the Malzoni Research Hospital in Avellino, Italy. Thank you again.
Thank you, Alessandra. Dr. Nafi?
Hi, I'm Tamer Nafi. I'm a consultant in IVF and reproductive medicine, and I've done my research in embryo implantation and implantation problems. I'm very interested in the effect of endometriosis on IVF, and I'm the Deputy Medical Director of Create Fertility.
Good. Now that you introduce yourself, we have a question for IVF. And
Okay.
here we have we have a question about also this one is important, and it is not 1 million pounds, but it's a very important one actually, and it's becoming more and more important now, about large endometriomas. Patient with a large endometrioma looking to conceive or trying to conceive, removing the cyst first, can this negatively impact fertility? AMH, ovarian reserve, egg freezing, so many things. And in a nutshell, what would you recommend a patient that has a large endometrioma that would like to get pregnant?
Well, the word large is quite definitive there, because if it's a large endometrioma, then this will have multiple negative impacts on an IVF cycle, even for an egg freezing. So even technical difficulties in collecting the eggs, and of course the growth of the follicles. So I would recommend surgery first by a reproductive medicine surgeon who will of course be quite careful about the ovarian reserve in their techniques. Small endometriomas, however, may not dramatically affect the ovarian response, and technically it might be possible to collect eggs quite effectively. And of course, this would probably mitigate the little risk of loss of ovarian reserve with surgery. So there is a place for IVF first in very small ones, but in large ones, I would always advocate the surgery first.
And just to add a quick comment is that surgery is a range of things. Surgery can be drainage, can be excision, can be sclerotherapy, alcohol, even if it's not, something that some like, some do not like. There is still a growing body of evidence about it. And there is, surgery is not exclusively excision of the endometrioma in this particular case. Do you all agree that we have other options and we can offer other options, especially if the patient has this desire? Because if we remove the endometrioma, yes, can have a negative impact on the ovarian reserve of that patient. Thank you very much, Dan. And Annemiek.
Yes, I would like to give the floor to Alin. Alin wants to comment.
Alin.
No, it was just a short comment before jumping to any intervention or surgery. I think the diagnosis is important. First of all, we need to know that we're dealing with an endometriosis cyst, because it's not always endometriosis cyst. We need to exclude malignancy or borderline tumor or other entities.
Perfect.
Yes, very important to add and to be aware. Yeah. So we are jumping to a totally different subject now, because we are going towards alternative or maybe complementary medication or medicine. The question is, could you explain what besides castor oil, packs and acupuncture in the alternative medicine work for endometriosis patients? Is there a chance these are going to be easily covered by the insurance companies? Well, this is a very this is a question depending on in which country you are living. But I want to ask Guri, do you see any chance to answer the first part of the question? What is your opinion? Do you have any?
Yeah, thank you. So yeah, regarding the insurance, I'm not sure, because that will be country dependent. But we do know that heat has some impact on pain. We do know that the TENS, the devices that give signals to the central nervous system that beats the speed of the pain signals, can reduce pain. It does not get rid of pain for most patients, but it can reduce it. And in Norway, if you have a physical therapist working with you with a TENS device, you can have it on a loan, meaning that you can have it for free, which is a good thing. You can, of course, also buy it, but you can also have it for free. So I think for us, it's a bit hard that we do not have medications, pain medications. It's not easy to have the referral system that you usually have for chronic conditions. And endometriosis is not listed as such in many medications or treatments. So it will become a lot dependent on the patient's finances and economy. And I really, both the patients group in Norway and we are speaking up loudly to try to change that, because it should not be costly to get proper treatment, and it should not be costly to get the treatment for a chronic condition as other chronic conditions have. Yeah.
Whilst you're here, Guri, before you move, wait a second, because there is another question about natural holistic treatment alongside with conventional medical treatment. So it is Do you have any comment on that as well? Natural or holistic treatment, medical treatment with endometriosis?
I think that it's a balance, of course, because it's regarding symptoms and what works for your symptoms. And one tip of the scale is the economy. Don't use a lot of money on things that you are recommended that doesn't work. So have a rigid system. If you start with something, measure it, make notes, and see that it works for you. Otherwise, drop it because it will be really expensive for you, or it can affect your life quality a lot if you reduce the diet. If you make a lot of things in your life, that makes your life quality poor, and if it doesn't work. So I think that in our century, we live in a different way than we did just 10 years, 20 years ago. So I do think that environmental toxins, I think that the diet, ultra-processed food, I think it means something for the symptom load for some patients. Maybe not all, and maybe it's just a small part for some, but for some it could be really beneficial to have a look at the way they live to control the symptoms. And with that, I think that the fatigue, the general feeling of being sick, the bloating, the endobelly, maybe those symptoms are more affected by those things. But again, it's not like the treatment for the disease, but it's a way to take control over your life and maybe find something that reduces the symptoms that you're experiencing. Yeah. But I am also a traditional doctor and a surgeon, so this is but I am really interested in giving back some of the power to the patients and to look at all the evidence that we are starting to get about the microbiome, about the diet, about the environmental toxin, and how they all affect this disease as well. Yeah. Thank you.
Seeing the interest, Gui, what do you think if we make a session on this? With microbiome and also the alternative medical treatments, etc. We need also to know more. Maybe this is something that we need to know the evidence about it, and we need to have more insight about the what is evidenced to be efficient and what's not, so that our patients know also that there are some stuff around that, but yes, not all the stuff has scientific evidence behind it, and not all the stuff can be beneficial and cost effective.
Yes.
Thank you very much.
All patients need to have the access to proper medical care.
Yes.
And to a proper diagnostics, and to have your disease diagnosed and treated properly. And then you can start working also with the little things that make your life a little bit better. Yeah.
Sure. And for our patients, I would like also to highlight that we are now establishing a website in which there will be a page, a forum, a platform that's only for the patients, that has reliable resources for our patients to also can go through. I know that there are a lot of reliable resources and patient advocacy groups, and here we have Lion from a very strong patient advocacy group who are spreading knowledge about endometriosis all through. We will have this on our website in the European Endometriosis League, so please join our website, and you will find some reliable resources also about the medical treatment, holistic treatments, and so many other things related to the management of endometriosis. Annemiek.
Yes, we have more than 70 questions on our list. And officially only 10 more minutes to go. So we are not going to finish all of the questions.
We will overrun a little bit.
A little bit, yes. But
we agreed with our
yeah,
experts.
that will be fine. But I read an important question, and I would like to ask this to John Morton. Although it is a question about Europe, but I don't believe in continents. I believe in the whole world. So the question is, in order to get a breakthrough in the diagnosis and treatment of endometriosis, ultimately worldwide, what are the most important next steps? John, could you comment on that?
Or next steps for endometriosis research, was that?
Yes, well, that's a question you can also answer. Go ahead.
Well, I would probably preface this answer by saying I'm a colorectal surgeon, so obviously I would be more interested in the deep endometriosis and the penetration to do with the bowel. We've heard several topics that have been touched on already. So the microbiome, I think, is a very interesting area that I think it's only microbiome generally, and I'm talking bowel microbiome, but I'm aware there's research in the vaginal microbiome as well. And I think that area is going to be quite rightly explored in detail over time, not just from endometriosis point of view, but obviously from cancer point of view. Which brings me on to the next part, which is the study of endometriosis and the genetics, I suppose, and the epigenetics surrounding endometriosis. I'll focus, and apologies, I'm sure you probably hand over to one of the gynecologists in a minute, but when you look at the genetics of where endometriosis occurs on the bowel, I think it's fair to say that a bit like your discussion about the adenomyosis, and whether that starts on the inside and works out or the outside and works in, there are different patterns for regard to the deep infiltrating endometriosis. Whether that's occurring on the sigmoid colon, the rectum, obviously the last part of the GI tract, or whether it's occurring on the appendix or the cecum. And the pattern is different and how they behave is different. But also at a microscopic level, whether they're infiltrating the nerves, and how that feeds into symptomatology. We've already spoken about how when you're assessing patients with endometriosis, the functional outcome is as important as anything really. And how do we, at the moment, we certainly as colorectal surgeons, I'm happy to be corrected by the expert panel now, we tend to look at the deep infiltrating endometriosis on the bowel as deep infiltrating endometriosis of the bowel. I do wonder in the future whether we will have additional genetic information that helps us work out what type we're looking at and therefore help us predict what we should be doing for these patients. We've heard the diverse way of treating all these different patients from different surgical techniques. Certainly within bowel surgery, we're all very familiar with shaving, disc resections, segmental resections, and how is that appropriate for everyone who's got the bowel endometriosis if we're going to do surgical intervention? Would it not be better to understand the actual pathogenesis of their endometriosis and therefore tailor the therapy very much for the patient themselves? I've probably spoken enough about the bowel aspects, and I might suggest you choose one of the gynecologists to maybe look elsewhere from a more pure endometriosis point of view.
Thank you very much, John. And here, sticking to the bowel, we have a question here, very simple, but £1 million. And maybe we can ask it to Atano. Shave bowel or disc, Atano? What do you think for bowel endometriosis? What would you, yes?
It's an excellent question. And I think it comes down to some basic principles and the multidisciplinary team. So it's about taking a thorough history, examination, and appropriate investigations. So the symptoms of bowel endometriosis include dyschezia, rectal bleeding, particularly cyclical, but it can also just feed into the general pelvic pain. And that's why the importance of the history and then the investigations is key. If the symptoms don't quite fit with what the investigations show, for example, on the MRI scan, if there's rectal bleeding without muscle invasive disease, and I think it's important to do a colonoscopy as well, just to exclude any other causes of rectal bleeding.
Say that I don't know, Ertan, if your opinion is the same, that we don't suggest egg freezing for all the patients who have endometriosis. There might be patients that can be at risk, at higher risk for reduction of their ovarian reserve, and they still would like to have a pregnancy. And these are a cohort of patients that maybe we can suggest this. We suggest all the options to all our patients, and they are absolutely happy to they can choose. But you can recommend egg freezing in a certain cohort of patients where they can be at high risk of reduction of their ovarian reserve. Do you agree?
Well, yes, of course. So in principle, I think, again, going back to what I said, that for people who do not have immediate plans to become pregnant, and therefore the impact of age in the coming years may become more obvious, and particularly those who had surgery or are due to have surgery for ovarian endometriomas, where we know that ovarian reserve will reduce after surgery. then egg freezing might be beneficial for this group of people with endometriosis. Otherwise, yes, it is difficult to generalize and offer a blanket policy of freezing eggs with everyone with diagnosis of endometriosis. And I think that is probably, there is a possibility of exploitation as well here, and then also waste of resources.
That's exactly why I asked the question. Okay, now that we have spoken about, hi Attila.
Hello, hi.
Thank you for joining. About advocacy groups, we had 3-4 questions coming about advocacy groups and the role of advocacy groups, etc., etc. And here we have Diane. Diane, can you please enlighten and give us some more insight about the advocacy groups and the role of advocacy groups and patient awareness in raising patient awareness about endometriosis and also in helping patients with endometriosis, please?
Okay, are there any of the particular questions that have cropped up that you would like me to address? Because there are a few, although I've tried to deal with them in the text.
Yeah, I can see some of them, but maybe if you take
Well,
the
so let me
yes, please.
let me deal with advocacy groups. So we exist in order to help patients better understand their disease, how to approach the right kind of doctors, and know what is the correct kind of treatment. We do this by not just sharing awareness, but by providing them with informational resources and helping them to learn themselves. Because our observation is that in order to get the best out of possible endometriosis treatment, patients need to be incredibly well informed. In fact, I've heard many surgeons say that they found that endometriosis patients are some of the best informed patients that they ever see, because we've had to do so much of the work and the heavy lifting ourselves. I would say our main role at the moment is to attempt to shepherd patients towards effective care. That's particularly difficult when we have issues like poor ultrasound, poor MRIs. I've listened to you all talking about very lovely, perfect scenarios where an expert will read an MRI. I can tell you that we've had recent research showing that overwhelmingly, certainly within the UK, I cannot comment for Europe, what tends to happen is a patient will be referred from a primary GP setting into a secondary setting. They will then have an ultrasound or an MRI performed by a non-expert, and they will be told they have no disease despite overwhelming symptoms, and then they will be told to go away and be signed off the service. It may have taken them 6 months, 1 year, or 2 years to get to that point. They are then knocked back to the beginning again. I can tell you from the 40 case study, which a fellow advocate has completed recently, over 86% of those patients who took those scans for a second opinion, over 100% of them had endometriosis identified, with 87% identified surgically and the other 13% still waiting. Our problem is not just a crushed health system, it is the lack of skill permeated through every single layer, every single touch point of the system. We exist to try and help patients navigate that, to give them the confidence so they can understand what questions they should be asking, to whom and why. And that's solely why we exist.
I have to say that you're doing a great job. And thank you very much.
There is much work to be done.
Obviously, but yes, there is so much to be done on everyone's side, not only on your side, not only on our side, not only on the institutional side, the governmental side, on everyone's side, there is so much to be done for our patients. And thank you very much for commenting on this, and thank you very much for existing. Thank you. Thank you. And I'm also glad that you're conducting studies and helping us also to understand where the points are and where we should and where we can move our resources and research to help more and more our patients with endometriosis. So here, Annemiek, we have some more questions, and probably we will go through most of them. but
Yes,
we will.
I think we have.
Yes, please.
There's a new topic that we have not addressed yet, and that's the topic of thoracic endometriosis.
Yes.
And I wanted to ask to Noor, could you comment on it? What do you think? How can we diagnose it? Because when I discuss with my cardiac surgeon, he says, "Well, I always want to do CT scan for diagnosing something in the thorax," and then I say, "But I'm used to MRI." So how would you diagnose this, and what would be your preferred treatment option, Noor?
Well, this is a very good question, and I think that we're still seeking, especially in the Netherlands, for good treatment options for thoracic endometriosis. I think the first where we have to start is to listen closely to the patient complaints and to be actively ask for the specific sites of endometriosis from the thoracic or diaphragm. And that is the first start. And we do know that, for example, we use most often MRI to diagnose it. And of course, laparoscopic surgery, sometimes we evaluate the upper abdomen part always to see if there's any diaphragmatic lesions. But we also know that we only see a part of the diaphragm and that you really have to do a good search to see the lower part behind the liver from the diaphragm. When we specifically screen for symptoms from thoracic endometriosis, then I think we use most often MRI, but we do know that lesions can be small and very hard to visualize on MRI. And the previous thoracic surgeon that we worked with mainly used surgery, VATS, video-assisted laparoscopy to visualize thoracic endometriosis. But I've also had cases where they did other types of diagnostics. But I'm very curious what other experts would say here, because I think it's very hard to have a clear diagnosis on these on thoracic endometriosis. Yeah.
Mm-hmm.
Yes, please. Your kick time. What do you think about this?
Comment.
Yes, Attila. Yes, please.
Sorry. So we have a very limited evidence saying that for thoracic endometriosis syndrome, the CT scan is more sensitive and specific, whereas for the diaphragmatic endometriosis, the MRI might be the better option. So there are two imaging techniques in two different symptoms.
Yeah, I find often you end up doing both, eh?
Yeah, most likely.
It's not preferable, I think, from the cost perspective, but I understand what you say.
Yeah, and Jörg, what do you think?
Yes, this is a very interesting question, because thoracic, very often you have pneumothorax and you cannot find the lesion. Sometimes when they do lobectomy, we find some endometriosis, but from the imaging point of view, it's not so easy, because sometimes they are very tiny in the lung. With the MRI, we identify the diaphragmatic, like Attila said. So I also follow this regime to do both. But in fact, the pulmonary in the lung is not so easy. So I have patients which he had several times pneumothorax, and finally in the lobectomy we find some small lesions, but it was not visible in CT or MRI.
Okay, so I have here some more questions, but one of them is about ultrasound and diagnosing endometriosis with ultrasound. And here we have two of the very, very experienced sonographers in Europe, Ligita and Alessandra. So, Ligita and Alessandra, what do you think about the use of ultrasound in a nutshell? Use of ultrasound in endometriosis. Good, bad, precise, accurate? What do you think?
Oh,
Would you?
thank you.
Yes.
Thank you for asking. We know that accuracy of ultrasound for the diagnosis of endometriosis, both pelvic and abdominal location, is really high in expertise. we raise 100% of accuracy in most of the sites with a very, very high specificity and very high sensitivity as well. Sensitivity can be a little bit lower in the right pelvic fossa for a small nodule in the small bowel, but concerning retrocervical area, parametrial area, rectosigmoid, and all the other pelvic location of endometriosis, ultrasonography in expert hands rise the same diagnostic accuracy of MRI. That I have to underline, it's also operator dependent. Also MRI in expert hands perform very well, but if it's performed by non-expert operator can show very, very high limits. So both techniques are recommended for diagnosis of endometriosis and for pre-surgical staging of the disease, of course.
May I
Ligita, yes,
May
please.
I add, I think, Alessandra, you're covering very good aspect when we have an expert examiner, and of course, before surgery, we do the scan, it should be done definitely by an expert. But I think many of our patients, they are being examined like a general gynecologist because they come with their symptoms, and not all patients have access directly to the expert, and many patients are going many years without disease because the disease is not always in the ovaries. And many gynecologists, they finish their examination, ultrasound examination, looking at the uterus, ovaries, and that's it. And I think this is the big problem because if we don't look, as we say, if we don't think endometriotic, we will never find a disease. So I think if we refer to those that are general gynecologists, I think they have to be aware of the disease and also get some kind of training, or also think endometriotic, or of course refer the patient to another colleague. We have really many patients that have been with deep endometriosis, went with deep endometriosis in the bowel for many years, and the gynecologist has never looked at the bowel and has been treating, and patient has been suffering from the pain. So, but I think ultrasound is an excellent tool if you know how to use it.
Yes,
Aline,
of
would you
course.
like to? Yeah, sure. Yes,
Oh, I'm
Alessandra,
sorry.
please. No, please.
Yeah. Yes, of course. I was speaking about accuracy in expert hands, but in an ideal scenario, any gynecologist should be aware of the possibility of endometriosis in patients that complain chronic pelvic pain, and if they are not able to use ultrasound and to detect even deep endometriosis findings, they should be aware of the possibility to refer the patients to a referral center in order to achieve the correct diagnosis in that patients, of course.
Exactly, and then also just very small comment that also the patients that are here at this meeting, you also have to be aware that we gynecologists, we have to be aware of the disease. So maybe you have been many years without disease, or maybe you have been told that you have endometriosis only in the ovaries. So be aware of that, and also ask the doctor. Maybe you can be also referred to an expert to find out how big is the disease in the pelvis.
So to sum up, I think the message here to our patients could be that, first of all, eyes do not see what mind does not know. Sometimes if we're not well trained to do ultrasound diagnosis of deep endometriosis, we will not see it. And the second very important message is negative ultrasound does not mean that the patient doesn't have endometriosis. Negative ultrasound does not mean that. Aline, please.
Yes, I have another £1 million question, because
Please.
both Ligita and Alessandra mentioned the word expert. So my question is, what is an endometriosis ultrasound expert?
Yes,
Can I
Alessandra, you have an answer,
Yes.
please.
In literature, we have several papers about the learning curve of gynecologists, and it's supposed that at least between 20 and 40 cases of deep infiltrating endometriosis lesion are needed to be visualized in order to get the ability to identify the lesion. So that is probably the starting point. An expert is an operator that usually is dedicated to gynecologic ultrasound with awareness of the disease, with great experience with ultrasonography technique, and that can show with data its diagnostic accuracy on, of course, on uterus, ovary, and deep infiltrating lesion.
Yeah, I agree completely with Alessandra. So I think we
So,
all agree with that we also need to continuous training as well. So it's not enough that you have look at 40, 50 cases and then you find, and then maybe you see a patient next month and then again next month, because we have to be exposed to these patients. And of course, to have a good ultrasound equipment for
yes, and maybe if this is the case, patient can be referred to an endometriosis center, where the endometriosis center has the surgeon, has the doctor, has the fertility doctor, has the pain therapist, the surgeon, and the ultrasound, and a team that has an expertise and background in treating endometriosis and in diagnosing endometriosis and in dealing with this disease at 360 degrees. We have some quick telegraphic questions with telegraphic answers. Sclerotherapy. Shaheen, what do you think? Would you suggest this to your patients? Is there a strong evidence? Because we have something like 7 questions about sclerotherapy.
Yes.
I'm just reading them.
So just to give a little background, I'm sorry, it's not so telegraphic.
Please.
That we need to understand that although excision is always the better way of treating endometriosis, when it comes to endometriomas, excising endometriomas reduces ovarian reserve. So we've been trying to find alternative ways to treat endometriomas. These are chocolate cysts. These are cysts that are inside the ovaries. Sclerotherapy is putting 96% ethanol inside the cavity of the cyst with the hope that the negative effects on ovarian reserve is less than peeling the cyst wall. The initial reports coming out of France from Horace Roman's group and from other places were very promising, but the more recent outcome results are not as good. So the jury is out, although it is potentially a good alternative to peeling endometriomas. There is no one size fits all. Sclerotherapy cannot be used in all endometriomas. That's one problem. And also, we still don't have enough data to be able to recommend it for everyone. But it's a good alternative.
Thank you very much.
Shaheen. And another very short question with a short answer to Powell. What about adhesions? How to prevent them and how to treat them if they are there?
Well, I think the best way to avoid adhesions during surgery is to maintain an operation field clear from any bleeding. Of course, we have plenty of product substances which are claimed to be effective to prevent adhesions, but honestly speaking, there is no good evidence. I mean, scientific evidence if any of them is of superiority. So this is the first issue, to make a proper, robust surgery without any bleeding left. Of course, there is also some individual predisposition to develop adhesions which we cannot omit, and sometimes, despite our best efforts, adhesions can persist or can appear. But I think the most important thing is what recommendation from 2022 highlighted, that the most important is very thorough qualification for surgery with a proper pre-operative workup, and that there should be there should be only one and proper surgery, not multiple surgeries which produced adhesions.
Yeah, agree. Thanks.
Thank you, Pavel. We are now trying to group the questions under one title, and then ask about the questions so that we benefit more rather than asking only one question. So we have here a question about the indications for surgery. Elvira, what do you think the key points or the points that determine you deciding for the surgery, and how do you counsel your patients about risks and benefits? Because here there is a question about who is candidate for surgery and how do you decide this? So please.
So the decision to proceed with surgery for endometriosis is based on several key factors, and I consider some key factors are severity of symptoms, and the extent of the disease and the patient reproductive goals. Surgery is typically considered for patients who experience severe pain that does not respond to medical treatment. Those with endometriosis related with infertility, special for repeated IVF failure, and in cases involving deep endometriosis that affect critical organs such as bowel, bladder, or ureters. And about the risk, to assess the risk versus benefit, I think we take into account the patient's medical history, because as you saw in the question that the patient sent us during this evening, a lot of patients has repeated surgeries. And the risk is depend on prior surgeries and overall health of the patient. So I think it's necessary to take all this risk into account when we indicate surgery, and all these key factors when we indicate of our patient the surgical treatment.
Okay, thank you very much, Elvira. And Annemiek.
Yes, another question which is a little bit grouped. There are many sub-questions to be thought of, but what's the general approach of endometriosis in adolescents? And I think it's a good one to ask to Taner.
Thank you, Annemiek. It's a very popular question. Many young girls are interested in the endometriosis because of the awareness increase the endometriosis. Thanks to that awareness, so they are afraid of they can have endometriosis or not. So the main problem is during that time, the question is how can you manage that conditions in the adolescent period? But it's quite the same in the later reproductive period. If they give us a good answer, the medical treatments, we can give a medical treatments and solve that problem with a medical way. But if we see some deep lesions, and that deep lesions can have a very eminent symptoms, in that situation, we know that there is a lot of peritoneal lesions in the adolescent period, and that some small lesions have a very big symptoms at the same time. So if there is no answer with the medical treatments, then we can recommend them the surgery. But if you recommend the surgery, we have to keep in mind that if you do the first surgery very early period, they are candidate second or third surgeries in the later life. And so we have to share all information before any decision, like medical treatment, like surgery, and then do the second step.
Yeah, I know I'm always balancing between not doing the right thing for them and let them suffer for a too long period of time, or being too aggressive. And especially in young women, I'm a little bit worried if what we are doing is the right thing.
Annemiek, sometimes people against the surgery, sometimes people against the medical treatments and jump to direct the surgery. You mentioned very well, we need the balance. If they need the surgical treatments, we have to explain the conditions and then we recommend the surgery. But if we treat that one in some simple pill, one pill in a day, then why you don't use that pill in that very young girls?
Yeah, agree. Guri, did you want to comment on that? You're muted.
Yes, thank you, Jess. I see a lot of adolescents, and we are a referral center, so many of them have already tried a lot of hormonal treatment before they come to us. My experience is that although surgery has its place, and maybe in the future we will know more about the genetics, meaning that maybe for some of the adolescents doing the surgery and doing the excision of the lesions will maybe prevent some of the development further on in life. I see much more extended endometriosis lesions just a couple of years further, 20 plus patients. But using physical therapy, using psychological support, having a team around the adolescents who usually fall out of school, I think is also key to make them get back into their lives. They need really a comprehensive treatment approach, and not only the gynecologist, but a team around them really early, not to get into more chronic pain and fall out of school and everything.
Thanks. Mohammed, you're muted.
Guri, while you're here, stay there, please, because I have a question about neuropathic pain. And what would you, in a nutshell, neuropathic pain, endometriosis, what would you comment and what would you like to say?
Great question. I think that, yeah. So in many patients, there is some part of neuropathic pain due to the inflammation, due to the pulling of the nerves, not always endometriosis on the nerves, meaning they need surgery on the nerves. It's just the environment, the adhesions, the pulling, fibrotic tissue that needs to be loosened and freed to help. I think also we talked a little bit about the hypogastric nerve and the bladder function, and we also use to measure how the bladder functions before surgery to know, like in the urodynamic laboratory, we try to check how the bladder function also before surgery, because sometimes the endometriosis has done its damage before surgery as well. I think it's nice to know. But I think to have a patient history that is thorough, to have an examination that also includes the neural function and the function of the bladder and the bowel and everything, and the sexual function is important to make a decision around your surgery and how you direct your treatment. But again, sometimes the nerves are screaming not because there is endometriosis on them, but because it's inflammation and pulling and irritation. Yeah, thank you.
Great, thank you very much. And Annemiek, we have some more questions, but there is one that you wanted to ask Attila about robotic surgery and the role of robotics in endometriosis.
I have a very clear answer.
Yes, this is why I asked you.
The thing is that we have zero evidence supporting robotic surgery in endometriosis. Actually, we have evidence in contrary that robotics is longer and definitely more expensive when compared to classical laparoscopy. So maybe in the future we will have some randomized controlled trials assessing the difference between robotics and the conventional laparoscopic surgery. But at the moment, what we can say that there is no evidence supporting the role of the robotics. However, I like robotics, so I think it's fun to do, and I also perform robotic surgery.
This was a provocative question, actually, and this is why I've seen people here who do robotics and looking at you like, Good. Shaheen, do you have a comment on this?
Yes. Attila, I know a colleague who did a randomized control trial comparing nodes, segmental resection, and found no difference, but still does notes because they believe in it. And I think that I like that colleague, and that's you. So I think sometimes, even though we have no randomized controlled trials, you know, the surgeon can see the benefits. And I think, although I'm not one that thinks that robotic is the answer, but I do think that there are benefits in the robotic route. Not for every patient, it's just a tool, but I do think that it does affect the outcome in some patients. And I can say that with confidence because I have a shoulder pain right now, and I just did a really long operation. And I was just thinking, if I had the robot in this hospital, it would have been much better.
Yes,
So
I know what you mean.
Yeah.
Jörg, what do you think about this topic? Because I will tell you the question.
Yeah,
because,
I
yes,
think I'm not experienced a robotic surgeon, but I think we have some very kind of rhythm with the movement, and in certain situations, the robotic, I think, is superior to laparoscopic surgery, especially for those who are not skilled with laparoscopic surgery. And you learn it much faster with the robotic, as I understand, than when you have to learn by laparoscopy. Probably both is very good, that the specialist should know both, but the robotic is good. I personally have sometimes the feeling that in total, we miss, especially except if you use two in dock stations. That means you can work with 4 hands. At the moment, surgery is done only with 2 hands. And in a very good laparoscopic surgery, the assistant is much more involved in the surgical procedure. But this can be solved in the future with special robots, no doubt. But in fact, I like it very much. And I think maybe in the future, we will have a hybrid situation with different systems. But we should go ahead and we should improve our technical equipment. That's my opinion.
May I just add one quick note, because we have lots of patients listening. The important thing that I really agree with Attila and the rest is it's about the surgeon more than about the tool. So nobody should think that because they had their operation robotically or laparoscopically, they had a better surgery or a worse surgery.
Yes, I completely agree.
Thank you, Shaheen.
That's very important. Very important that that the robot per itself, it doesn't work by itself, and that's why sometimes people are asking for a robot. They don't ask for the expertise.
This is exactly why I asked the question and why I've selected this question, because the wording of the question was, does robotic surgery improve patient outcome? And I wanted to learn from you all how you look at it. Robotic is just a tool, is just an instrument. In expert hands, and this is the most important thing, experienced surgeons can use a laparoscopic tool, can use a robotic tool, can use a robotic tool in selected cases, yes. But the robot does not do the surgery. It is the surgeon that does the surgery. It's the center that diagnoses beforehand what this patient needs as a surgery, offers her a multidisciplinary approach, 360, fertility treatment, egg freezing, sclerotherapy, all the options, but it is not only a robotic surgery that improves or worsens an outcome of the surgery. So we have still questions. Annemiek, what shall we do? Do we have any comments from the experts who are sitting here? Diane, do you have any comments?
I think one of the things that I understand the European Endometriosis League is doing a lot of work, particularly with attempting to raise standards, and that's great. But patients are also seeing other worldwide, shall we say, surgeons setting up clinics in both the USA and Europe. And then we have the BSGE centres in the UK. And what I would say is what we are very frustrated about, some of the same things as you, which is what is endometriosis? How does it progress? How do we tell? How do we treat it? How do we most help patients? Why do we not see greater levels of collaboration completely and internationally? From our point of view, we see Surgeon A setting up a range of clinics and telling us that he's the best, and if we just pay him enough money, that he will solve our problems. We have a collapsing NHS system, frankly, where the pressure on BSGE systems is huge, with more patients than could possibly get in the door. But mostly what I do not see are some of the, and I want to say with all due respect, as some of the people on this panel, I deeply respect their work. There are many people here whose work I have read over and over again and deeply admire them. Many I have met, many I have interacted with. Where's the collaboration? From our point of view, what we see are silos. We see surgeons working in silos, or we see researchers working in silos, and we see a lot of you guys talking to each other. What we don't see is a lot of you addressing us. We're having to shout to get heard. We want to be part of these conversations. We have things to say, and we have, helpful things to say at that. So I would like to see more collaboration, please.
Thank you very much for this, and this is the reason why we invited you to be with us here, and thank you very much for accepting the invitation, because we want to build and construct bridges with us, with patients, and this is why we have an event with, thankfully, a big number of patients here with us, big number of doctors, and I will tell you more. We answering the questions that have been raised by what we did when we started to be on the board of the EEL is that we asked the patient advocacy groups and we asked them, what do you want from us? And the first answer was, we want to know where to go where we have endometriosis. And this is why over a good number of months, investing a good number of energy and putting all these people, many people together, we made a Delphi consensus conference where we had the people, experts from all over the globe, representing different societies, ASHRI, ASGE, BSGE, AEL, AAGL, sitting all together, either virtually or face-to-face in Marseille, in London, answering the question, what are the criteria of an endometriosis center could be? To avoid what you're saying, person sitting a clinic here, a clinic there, or we wanted to speak a global language and put all the things together. And fortunately, we submitted this for publication on the Lancet, and it should be in the way to be published. And this is one thing. The other thing is we are starting to making an EndoEnage project where we are trying to engage with all the stakeholders, with the industries, with the patient advocacy groups, with especially with the patients, because the main drive for what we do is you, the patients and the patient advocacy groups. So thank you very much for raising this, and I hope it's true that we are at the start, at the beginning, and we are all at the beginning, but this is just a small step, and thank you for guiding us and helping us with this. A small step towards achieving and satisfying our patients and making some achievement. And obviously the results of these studies were not only about the centers, but were also about scores to assess objectively the surgeons. And we concluded that we will come up with a statement, all of us, and whatever this statement can do, we will see. We can raise it to the European Parliament. Pavel Basta, and most of the people sitting here are involved in national committees addressing endometriosis care in their countries, and they've raised this, Guri and Pavel and others, to the authorities to help raising more awareness and doing more efforts to change the map of managing endometriosis. So thank you very much for this. Any other comments? Any other questions? Aline? Perfect. So I can see that we still have some questions that we couldn't answer, but unfortunately we have to conclude. But having seen this this extensive, this involvement, and also having heard what Diane is saying, and thank you very much. We will do much more of these events. I mean, this is one, and we actually, when we thought about it, we said, fine, we will be there. Someone will join, who knows? But we had more than 300 people joining at the meeting, and we are so proud of this, and we are so grateful to who joined, so grateful to the faculty and to the panel of expertise, to Diane, to all the patients and the colleagues who are joining. I'm extremely sorry if we couldn't answer all the questions, but I will personally try to answer and send them via email to the ones that I can. The ones that I cannot and I'm not able to, I will send them to the colleagues who are more interested in the fields, I don't know, of infertility or neuropelviology or fields that I'm not. Jörg, you wanted to say something?
I just want to comment also to
Please.
Diane's wish. For me, it's so important that we claim also for the same expertise in imaging as we ask for the surgical approach. Because the surgery has become very popular, and I know that from the very beginning in deep endometriosis, it's not the case what we can remove. We have to find out what we should remove and what can we leave behind. And therefore, the imaging is so important, and we have to expect the best imaging before we go to the best surgeons. And this sometimes is missing. Sometimes the patient always starts with surgery. And I'm a passionate surgeon, but I can do the best result is when the indication is the right indication. And that's so important. Surgery is handicraft, but indication is science, and indication is imaging. That's my message also for the patients.
I totally agree, and I cannot agree more, Jörg, about the indication and about the 360, the holistic approach, starting from diagnosis, listening to the patients, providing so many things as we heard here. And this is why also we are here with a team of diagnoses. We have ultrasound, and we have fertility doctors, surgeons, medical management, etc., etc. So again, for the questions that haven't been answered, that are not actually so many, we promise that we will answer them. We also promise that we will do much more of these events, because we didn't imagine that, I personally didn't imagine that I would have this big number of participation. So thank you very much. I'm very grateful for this. We will do them frequently. We will just try to see if we can do these events once a month or once every 2 months. The other promise for Diane is that we will do our best and to involve all the patient advocacy and all the friends from like yourself and others. And last year we had a very nice meeting in Cambridge, and we invited Nancy Peterson, and she was there. Unfortunately, she's not here today. But yes, we will do our best for this. And again, so many thanks for expert panel for being here with us, for our patients. Annemiek, would you like to comment on something?
Yes, thank you. I would like to thank you, Mohammed, for hosting this and for organizing it. And I would like to thank all the faculty, because you have been very active and very skilled. And I've seen all those positive feedback in the chat. Many people gave us kudos, and I'm really happy for that. Thank you for attending in such big numbers, and also thank you for being constructive and respectful to each other, as well as in the chat as in the discussions.